Okay, so this is the Ruth Barzcic Physiology Review Part 2. We're going through the mastery questions. This is number 9. What channel is most responsible for the fact that the resting potential of a cardiac cell is so negative? It is IK1, or the inward rectifier. The reason is because the inward rectifier is open at the resting potential at -90, whereas pretty much most of the rest of these channels are closed. I mean, you've got a little bit of leak here and there, but by far the biggest conduction is potassium through this channel at the resting potential. So remember, we said the higher the permeability to the ion, the closer the resting membrane potential will be to the equilibrium potential for that ion. In this case, the reason why the potassium permeability is so high, and the reason why your resting potential is so close to EK, which is about -95, is because this channel is so open at rest, whereas the other channels are really basically mostly closed at rest. Okay, so you can just look at the way that this current changes with voltage, and you can see it's highest. The outward current is highest at right down here toward the resting potential. Okay. Skeletal muscle, nerve, and action potentials rapidly depolarize. However, cardiac muscle rapidly really repolarize. However, cardiac muscle action potential is very long, having a plateau phase. What is the explanation for this? When you look at the plateau phase, when you look at the plateau phase, these are the currents that flow during the action potential. Inward currents are black, outward currents are yellow. When I say ignore this, some people think that the sodium-calcium exchanger reverses at this phase 1 of the action potential, and that you actually have sodium going out rather than coming in. That may or may not happen. The evidence is shaky, in my opinion, and so and it's not medically relevant either way. So my advice would be ignore this. We consider the sodium-calcium exchanger to be an inward current, that is black. Okay, and because these two currents are flowing during the plateau, bringing positive charge in the form of calcium here, and in the form of sodium to the sodium-calcium exchanger, you tend to make the voltage hang up. In other words, these two currents are depolarizing the membrane, trying to make it rise. These other currents, the delayed rectifiers in particular, and the chloride current to some extent, are trying to bring that voltage back down toward rest. So you get this tug of war going on, and the voltage hangs up really as long as these currents are active, and as long as the delayed rectifier hasn't built to the point, the IKS really mostly hasn't built to the point where it overcomes these inward currents. Okay, and that's why you have a plateau phase. And that, of course, is necessary because you need calcium coming in order to cause contraction. And, of course, calcium will be going out in order to cause relaxation. And you can see this really peaks in phase 3 as the voltage is coming down. And, of course, it's active at rest as well as diastole is developing and going on. Okay, so how does beta-adrenergic stimulation of SA nodal cells result in an increase in heart rate? So here we have our beta-adrenergic agonist, or norepinephrine if we're talking about a baroreceptor, baroreflex, that activates GS, that activates adenylyl cyclase, which increases cyclic AMP, increases protein kinase A, and that does a number of things, including, in the case of the SA nodal cell, increasing calcium current and increasing the funny current, which is also the pacemaker channel. So you'll notice that this pacemaker channel is active during phase 4. So you get repolarization, and the pacemaker channel opens at negative voltages, but it opens really slowly. So as the pacemaker channel opens, our voltage rises because we're bringing in more and more sodium. This channel does conduct potassium out as well as sodium in, but predominantly it's sodium in, and that the net effect is to depolarize the membrane as you bring sodium in. And so as you bring more and more sodium in, as this channel opens more and more and more, the voltage comes up until you hit threshold, and then you fire the SA nodal action potential. So the more you activate this channel, the more you make it open, the faster this rise takes place, and the faster you get to threshold, and the faster you fire another action potential. In other words, you increase your heart rate. So that's one thing that beta-adrenergic stimulation does. The other thing is it increases this L-type calcium current. The L-type calcium current, remember the L-type calcium channel is equivalent to the sodium channels in other tissues that have that fire action potentials. In other words, calcium is carrying this upstroke instead of sodium. So in other tissues, we say if you have more sodium channels, or if you make them more prone to open, then what you'll do is you'll lower the threshold potential. You'll bring it closer to rest and make it easier to fire an action potential. More sodium channels, or more easy to open sodium channels, the lower the threshold and the easier it is to fire an action potential. So in the SA nodal cells, calcium channels are equivalent to sodium channels. So if I activate more calcium channels, I bring the threshold potential down, and it's easier for this phase 4 to hit threshold. In other words, it'll hit threshold sooner because it doesn't have to go up as much. So these two things combine to increase the heart rate, and that's why you get an increase in heart rate, primarily why. For our purposes, it's why you get an increase in heart rate when you get beta-adrenergic stimulation. Okay, you have a patient who has a mutation in the genes encoding the chloride channel. What will this do to the ECG? So the first thing that you have to recognize is the fact that your equilibrium potential for chloride in muscle cells is about minus 55. In most other cells, pretty much every other cell, it's the resting potential. But in this case, it's not the resting potential because you spend roughly 1/3 of your time depolarized and 2/3 toward rest. In most other cells, you spend 95% of your time at rest or more. And so the chloride equilibrates, and your EK is equal to the resting potential because that's where you spend that's what your VM is the majority of the time. In the case of in the case of chloride, because you're spending 1/3 of your time depolarized, your ECL is higher than rest. And so it's about minus 55. Well, what that means is that chloride is dragging you down toward minus 55 during the plateau phase. It's dragging you up toward minus 55 when you're at rest, okay? It's always dragging you, like every other ion current, it's always dragging you toward its equilibrium potential. If I have a mutation that decreases chloride conductance, that means I have less outward current during the plateau phase. And that means my plateau phase will be shorter. And or will be longer, excuse me, because chloride, which is usually dragging me down, won't be dragging me down as much. So I get a longer plateau phase. If I lengthen the plateau phase, what will that do to the EKG? Well, here's my action potentials as they conduct through the heart. They're lined up in time here with my EKG. So I start at the SA node, I fire an action potential. My action potential propagates through the atrium, okay? And as it does that, I get my P wave here. My action potentials here, and the atrium correspond with where my P wave is in my EKG. I then enter the AV node, and when I'm in my AV node and I'm depolarizing my AV node, I'm in my PR interval. That is, I'm in this flat part between the P wave and the QRS. Okay? And then after a long period of time, relatively long, about 130 milliseconds, my action potential exits, and I go down along my Purkinje fibers, along the endocardium, and then I get a nice smooth propagation from inside to outside across my ventricular walls, a nice smooth contraction. So my propagation through my ventricle is taking place as my QRS takes place. And you can see these action potentials that are in the ventricle. In time, they're lined up with QRS. And then I start to get repolarization from outside to inside, and that's what generates my T wave. And my T wave lines up with my repolarizations of my ventricular action potentials. So during my ST segment, I'm depolarized everywhere in the ventricle. And then as repolarization takes place, my T wave hits, okay? So during this, so you're in the plateau phase during this ST segment. So if you lengthen the plateau phase, you're going to lengthen this ST segment, and your T wave will come later. So another way of saying that is that your QT interval will increase, and you'll get long QT syndrome, as was demonstrated in the exercise that I gave you guys to work your way through. Okay, so that's what you would see on the EKG or the ECG, a longer QT interval or a longer ST segment. Okay. What are the characteristics of K current through the inward rectifier? The inward rectifier channel is always open, always, no matter what the voltage. But it likes to conduct potassium at lower voltages. So as your voltage goes up, the properties of the channel are such that it won't let as much potassium through as the voltage goes up. So the potassium current goes down as the voltage goes up, let's say during phase 0, and it's actually pretty low during the plateau phase, let's say at about plus 10 here or something. Not non-existent, but pretty low, okay? And that's because of a property of the channel. That's why we call it a rectifier. It's an inward rectifier because it tends to like to conduct inward current. Another way of saying that is it likes to conduct current at really low voltages. Now, you never see this inward current because your voltages never actually get that low physiologically. They never get below the EK, which is about minus 95. But nevertheless, it holds that as the voltage goes up, this current drops. And so the channel is always open. It's not a gate that's closing or anything like that. It's just that the channel just doesn't want to conduct potassium at higher voltages. Okay, so inward rectifier channel. And again, that's primarily responsible for holding you at your resting potential because that's where it's mostly open. And you can actually see that here. Your inward rectifier mostly open at the resting potential here, and it's certainly relevant to the rest of these currents, pretty big, okay, at that resting potential. So our next question, you have ventricular myocytes and hearts that are affected by ischemia. They have longer action potential plateaus. What changes in which channels might tend to make this happen? If you have any kind of an increase in inward current, let's say an increase in calcium current or sodium calcium exchange current, that'll lengthen this plateau because you'll be bringing more positive charge in, and that will tend to make the voltage hang up longer and higher. Okay. On the other hand, if you have a reduction of any inward current, these are the inward currents. And if you have an increase in inward current, you lengthen it. If you have a reduction in outward current, that's the yellow. The delayed rectifiers, IKR, IKS, or perhaps chloride current. If you have any kind of a reduction in those currents, then you're going to tend to lengthen this plateau phase as well. Okay, so it could be any of that. In fact, what does cause these longer plateaus is actually an increase in sodium current during this plateau phase. For some reason, during ischemia, your sodium channels don't want to inactivate as well. Now, the vast majority of them do, but you end up with a very small percentage that don't want to inactivate, and they remain open during this plateau phase. And so you have extra inward current coming in, and that tends to lengthen the plateau phase. And as you know, after going through the long QT exercise, that tends to increase your potential to get triggered arrhythmias through EADs. Ventricular myocytes and hearts that are affected by ischemia have longer action potential plateaus. Assuming that the heart rate is the same as a normal heart, what would happen to ECL? Well, I said that your ECL is minus 55 because it's between the resting and basically the plateau phase here. You spend 2/3 of your time at rest, 1/3 in the plateau phase. So you end up just a little bit higher than rest. It's about 2/3 of the way down toward rest, about minus 55, just because you spend more time at rest than you do depolarized. Well, if I increase the amount of time that I spend depolarized, then my ECL will tend to be less negative and it'll rise, okay? So what'll happen is my ECL will be higher than minus 55, and I think in the long QT exercise, we actually called it minus 35, okay? All right. Explain why class 1B antiarrhythmics are effective in preventing arrhythmias in cases of ischemic heart disease. Well, as I said, in ischemic heart disease, you tend to get these sodium channels that are inactivate, that don't tend to want to inactivate, and that lengthens the plateau phase. So these class 1B antiarrhythmics, first of all, they tend to want to block the sodium channels more under conditions where oxygen is low. That is, when you have a low pH, things like that. Okay, so they tend to bind more during diseases like that, and then when they bind, they tend to make these sodium channels close. In other words, they tend to prevent them from conducting sodium current, and so they tend to reduce this plateau phase. And if you reduce the length of this plateau phase, it makes getting this EAD and this triggered arrhythmia less likely. Okay, and that's basically the theoretical mechanism of action. What effect on EKG would you expect if you gave a normal person a class 4 antiarrhythmic? A class 4 antiarrhythmic is a calcium channel blocker. So remember, in your AV node, calcium is what's carrying this upstroke. So you would expect a calcium channel blocker to act like a sodium channel blocker would in other tissues. And of course, we know sodium channel blockers will increase threshold potential, making it harder to throw an action potential, okay? And they'll also decrease propagation speed. And that's exactly what happens here. So your AV node, when you're propagating your action potential through the AV node, you're in this flat part, this PR interval. If you slow that propagation down and make it more difficult to fire an action potential, you will increase this PR interval. And so you'll begin to see what they call heart block, which I know Dr. Shah went through with you a little bit when he gave you an introduction to the EKG back with James Parker. And then, of course, you will probably, by the time you watch this, have gone through EKGs ad nauseum with Dr. Patwari and company. So now you know a lot more about them. All right. So an increase in the PR interval would tend to be what you would get first-degree heart block, basically. And you do see this in patients with calcium that are on calcium channel blockers. So it's something you should be aware of. Why doesn't a delayed rectifier potassium channel need an inactivation gate to close like the sodium channel does? Well, the potassium channel opens when voltage goes up, and it closes when voltage goes down. And of course, the more active your potassium channel, the more positive charge you have leaving the inside of the cell, and the more the cell wants to repolarize. So you have a regenerative reaction going on where the high current makes the voltage want to go down. When the voltage goes down, it tends to close that activation gate and therefore shut down your potassium current. And so your potassium current naturally closes the activation gate and naturally closes the potassium channel. And so eventually you end up closed at the resting potential because that's where your activation gate is fully closed. So that's why you don't need an inactivation gate. Unlike a sodium channel, which would never close unless you had an inactivation gate. Because sodium tends to make the voltage go up, it doesn't tend to make the voltage go down, so it wouldn't close itself. The inactivation gate has to inactivate it. which are not a characteristic of all action potentials. So that's my way of saying study the characteristics of all action potentials. These are the characteristics. All APs are all or none, non-decremental, unidirectional, and have refractory periods. So if I were to make a multiple choice question out of this, I would have, all four of these or three out of the four, and then I'd have one that would have nothing to do with all action potentials. That wouldn't be a characteristic of all action potentials. Which of these would increase the threshold potential? So this would obviously, if it were a multiple choice question, would have a bunch of things that might do something to the threshold, but only one that would increase it. In this case, the things that increase the threshold potential that you should be aware of: fewer sodium channels, make the threshold potential go up, that is farther away from the resting potential, so it's harder to make an action potential fire. Increased resting membrane, potassium or chloride permeability, or another way of saying that is a decrease resting membrane resistance. Either way works. So these are channels that tend to drag you down toward rest, so the more of them that you have open, the harder it is to get the voltage to overcome them and to get that regenerative reaction going where you get a phase zero. And then decreased rate of depolarization from rest. The slower your rate of depolarization, the more the inactivation gates in the sodium channels have a chance to close before you get that regenerative reaction going. So you want fast depolarizations that open those activation gates quickly and don't allow enough time for inactivation gates to close. That's how you get a nice regenerative reaction going. Okay. In our Ruth Barzcic CBCL, I was responsible for, or partly responsible for, a couple questions. One was this Robert Park vignette, which actually was written up by Dr. Hartley. A very clever vignette, I thought. Robert Park has atrial fibrillation, and all of a sudden his blood pressure begins to fall, his heart rate rises, and he's not feeling too good. So the intern does carotid massage, and so the first thing that we asked you to do is basically draw all the structures associated with a barrel reflex response. That's what this is involved, and make sure you include all the nerves, the tissue targets, and the neurotransmitters involved. So you're causing a local increase in the carotid sinus, and that makes the baroreceptors think that the arterial pressure has gone up. So you increase the action potentials in the nerves to the medulla. That increases parasympathetic tone to try to bring the heart rate down. And of course, your parasympathetic neurons at the SA node, the AV node, and at the atrium release ACH. Okay, so you have decreased parasympathetic tone. You have increased parasympathetic tone. You have decreased sympathetic tone. The sympathetic neurons are releasing norepinephrine at the atrium and at the ventricle and at the AV node and the SA node. And norepinephrine is what's involved there. Now notice in our ganglia here and here, I have ACH being released. That's because your ganglia use acetylcholine as neurotransmitters. So this is your preganglionic neuron, this is your postganglionic fiber, and ACH is released in the synapse in between. Same thing here, you have a long preganglionic neuron in the vagus, and then a short postganglionic, and you have the ACH being released in between. And then notice that your sympathetic outflow is also decreased to the blood vessels. And so this will cause vasodilation. And notice that the relevant neurotransmitters at the blood vessels, you have norepinephrine, of course, but you don't forget you have ACH released from some fibers in some of the blood vessels in the tissues like skeletal muscle. This is what's responsible for your anticipatory response. When you start to exercise, you get an initial vasodilation, and then you get vasoconstriction, which is the dominant response to exercise. So don't forget, ACH can be released from, and that's called sympathetic cholinergic activation. Review the autonomic nervous system section, if you don't remember what that is. And then don't forget your adrenal medulla, which I drew in rather sloppily here. This is effectively a preganglionic neuron. It releases ACH and activates the cells of the adrenal medulla to release epinephrine, not norepinephrine, epinephrine into the bloodstream. Okay, and that's part of the response as well. Finally, we have a concept diagram which explains why Robert Park's mean arterial pressure actually rises. Now, this can be very confusing, and if it didn't come across during the session, please listen now, because these responses to increased local mean arterial pressure, the decreased heart rate, and the vasodilation, they tend to make MAP go down, not up. So you may be puzzled as to why Robert Park's mean arterial pressure actually rises when you do this. Here's the reason why. You get the increased local detected MAP despite the fact that it's falling. That increases the impulses to the medulla, and that decreases the heart rate, just like we said in the previous diagram. But here's where the difference is. Robert Park's heart rate has risen so high that you've actually limited the amount of time that the ventricle has to fill. And so you've got less time to fill during this tachycardia because the heart rate is so pathologically high. Now notice this does not normally happen in a normal person. If you and I jumped on a treadmill and started running, our filling time would not be limiting. Our ventricles would fill. We have a fast filling phase that keeps our ventricles relatively full, and there's very little fall in the preload due to the fact that our heart rate is risen and due to the fact that our time of diastole is decreased, which you know happens now. Since you did the long QT exercise, we did exercise as a part of that, and you'll recall that the time of diastole decreased more than the time of systole did. So even though that takes place, your filling really doesn't become limiting, and so it really isn't a factor. But here the heart rate has gotten so high that even with rapid filling, there isn't enough time for the ventricle to fill, and so the preload has dropped, and that's why Robert Park's cardiac output has dropped, and that's why his mean arterial pressure has dropped, despite the fact that his heart rate has gone up. So by slowing the heart rate here, as opposed to what you would normally think, decreased heart rate, decreased cardiac output, what you're actually doing here is you're actually allowing more filling time. And that increases your stroke volume, and that results in a net increase in cardiac output and an increase in MAP, not a decrease. And that's why during this pathology, you get the opposite response that you might expect. It's because by allowing more time to fill, you actually make this cardiac output go up, not down, and you actually increase the MAP, and Robert Park begins to feel better. Okay, this is the other activity I was involved in. Consider the EKG from activity 1. You know that this is atrial fibrillation, and you will note the absence of P waves, the irregular rhythm, and therefore the irregularly spaced QRS complexes, and the tachycardia. And so, you know, I said basically explain why you see those things, and then I said you treat a patient with a calcium channel blocker, and why do those things tend to, well, get better, or at least why does the patient tend to get better? So here is my concept map. The upper part, the red part, is why atrial fibrillation causes the changes that you see. Atrial fibrillation is a state where you get a wave of depolarization going around and around the atrium, and it's such that the atrium never completely repolarizes. So you have this reentrant circuit going on where you have this wave of depolarization going around and around. Because you never get a depolarization of the entire atrium and then a repolarization of the entire atrium, you don't actually get a P wave. You just get this this wave going around and around, and maybe you get this, irregular sort of like little up and down if you look closely, but you never actually see a P wave, okay? And that's because you never get a full depolarization of the atrium where a P wave might be generated. The action potential randomly hits the AV node, and that causes your AV nodal action potential to fire randomly. Okay, so here we have or wave of depolarization, and you're hitting randomly, wham, and then maybe waves will go around and around, and then wham, you'll hit it again, and then wham, wham, you'll hit it 2 times really quickly. So you get this really irregular rhythm because your wave is going around and around, and it's hitting this AV node almost at random. Okay, and because that happens, you get random propagation to the ventricle, and you get irregularly spaced QRSs and an irregular rhythm. And you get tachycardia because even though it's randomly hitting the AV node, it's doing that still relatively rapidly, and so you're getting a relatively rapid heart rate. Okay? What does a calcium channel blocker do for this? Well, first, you increase the threshold potential in the AV node, and I explained that earlier in this review video, where calcium channels are effectively the equivalent of sodium channels in the AV node. They carry that upstroke. Blocking calcium channels has the same effect as blocking sodium channels. You raise the threshold potential. That makes it harder to fire an action potential in this AV node. And it also slows the propagation through this AV node. And because it slows the propagation, slower upstroke, slower propagation, you get a longer refractory period. And as long as this AV node is refractory, the action potentials can hit the AV node as many times as they want. As long as depolarization is taking place, and as long as the membrane is depolarized, as long as the AV node is refractory, those action potentials won't do anything. So you'll have atrial fibrillation, you'll have action potentials hitting this AV node that don't do anything because the AV node is refractory. And then eventually you recover, and eventually, the action potential will get through, but it takes longer for that recovery to take place because you're depolarized longer, because you've slowed the propagation rate through the AV node. Okay. Don't forget that blockade of L-type calcium channels will actually cause your cardiac output to fall as well. So this is a side effect. Decreased calcium influx through the channel. First of all, that brings less calcium into the cell, so you get less contraction, less binding to troponin C. You also get less calcium to be taken up into the SR, and that combined with less trigger calcium being brought in through the L-type calcium channel reduces calcium-induced calcium release. That also makes less calcium to bind to troponin C and decreases contractility, decreased force of contraction of the cardiac muscle, that decreases stroke volume, decreased cardiac output. So that's a side effect as well. Don't forget about that. And there is our blocked L-type calcium channel, and the reduced calcium into the cytosol. The reduced influx causes reduced uptake. Reduced SR calcium content causes less calcium to be released, along with less trigger calcium here, meaning less calcium opening up the ryanodine receptor. And that reduces calcium, and that all ends up adding up to reduced calcium for contraction. Okay? Thank you for your attention.